Hello, everybody. My name is Lisa Rimba. As she just said, I am a diagnostic hematopathologist. And it's not often that we get a chance to talk to patients. So I'm really, really super excited to be here and talking to you all today. So I am in Scottsdale and I'm in my office and I have my trusty microscope over my shoulder here. So let's get started. My plan is to talk for about 40 minutes and then let you ask in with your questions. When I've done this before, I've actually had quite a few questions from patients. I'm going to try to cover three areas. The first one is sort of just what happens to your biopsy. I think that people get a biopsy taken, they go home, 3 or 4 days later, their doctor, their hematologist, their surgeon calls them and says, "This is what we found. This is what you have." But what happened in that time period? It's sort of a black box. So I want to reveal the black box to you, and then a little bit about just lymphoma basics, which many of you probably already know, and then sort of approach to classification and kind of where classification in the future is going to go. So just right now, I think most people don't know what a pathologist is. I know when I went to medical school, I didn't. I knew about the pathologists on TV that did crime, but that's a very small part of our profession. We all went to medical school. I went to medical school in University of Arizona in Tucson. I did general pathology training there. So it's all looking at all types of biopsies and also running all parts of the lab, from the blood bank to the microbiology lab, the chemistry lab. Then I did special training just in hematopathology at the University of New Mexico. And then I've been faculty at the University of Florida in Gainesville, and then I came back to Arizona, University of Arizona in Tucson, and then to Mayo Clinic in Arizona. So my clinical practice is I do interpretation of blood and bone marrow and lymph nodes and tissue biopsies with a focus on leukemia and lymphoma. And then I also do a lot of research on new molecular specialized testing for lymphoma diagnosis and outcome prediction. I also do participate in running a tissue bank, collecting materials that can be used for research. So with that, we'll get started. I have a lot of pictures and I hope it's not too much, but I thought it would be interesting for people to see what does a lymph node look like when it's still in your body. So this is a picture of somebody having a lymph node biopsy. This is a surgical towel here. These are the retractors, their skin, and then all this red here is actually just a little bit of fat and then with a little bit of blood. And then this little gray, pearly, soft piece of tissue in the middle is what a lymph node looks like. Now, when you take the lymph node out and it's just sitting on a towel here, they don't look too impressive. They're just small little pieces of kind of grayish brown, soft material, a little harder than Jello, and they come out. And what happens then? So you go away, you get stitched up, you're going to go home or whatever is going to happen. The tissue gets picked up from the operating room or the clinic, and it gets picked up right away, usually within the first hour or sometimes in the first minutes, and it gets examined by a pathologist, or we have pathology assistants that work in the lab. If requested by the surgeon, and this may have happened to some of you, the tissues can be snap frozen for a very quick look. It's called a frozen section. We do this because it's quick and convenient, but it does use up tissue and it's not that accurate because you take the tissue and literally we dunk it in liquid nitrogen and it just freezes, but there's also ice crystals and it kind of shatters, but we can look at it and sometimes that's helpful for saying, yeah, it looks like it's going to be a lymphoma, or no, it looks like it might be an infection, or no, it looks like it might be another type of cancer, breast cancer, lung cancer, something like that. So we can get some general ideas. Also, in other types of surgery, this is done to look for margins around tumors. Not as important in lymphoma, but we do frozen sections all day long at the hospital, but just not that often for lymphoma. Okay, so then what happens next? So this is still the same day of the surgery. A normal lymph node coming out looks a little bit, it's about the size and shape of a small lima bean. Okay, so it's kind of a little oval thing that's sort of a little bit flattish. This is a centimeter, so it's only about a centimeter. That's the upper size of normal for a lymph node, and a centimeter is about half an inch. So that's the biggest that a lymph node really should be, unless it's getting reacting to something. An abnormal lymph node would be enlarged, and this one is showing you here centimeters. This is 3 centimeters. So it's about 3 centimeters by 6 centimeters, right? So that's like 1.5 inches by maybe 3 inches. So big, bigger than it should be. And when you cut it open, and we call this the cut section, or the central section there, it's just very tan and flat looking, and this one's kind of glistening, which is typical because it's wet. But really no structure that you can see. And we just call it sort of this fish flesh kind of appearance. And when it's enlarged and big like that, then that's lymphoma. If you've got a firm or nodular part, now this one has actually some hemorrhage in it, so it looks very dark, but you can see this particular area is very different than the rest, and this would be very hard and gritty. This is what like a metastatic disease would look like when it goes to the lymph node. So if, again, a breast cancer went to a lymph node, or a lung cancer or colon cancer goes to a lymph node, it will set up like a colony essentially of tumor cells there, and it can become very hard. So this is all done. This is still day one. This is the day of the biopsy. A couple more close views. This is two more types of lymphoma. They all look the same, though. We can't really look at it and say, oh, it's going to be this type of lymphoma or that type of lymphoma. This is a lymphoplasmacytic lymphoma. Some of you may have that or have heard of that. Looks the same really as the picture I showed you on the last slide. This one is a follicular lymphoma. You can see sort of little bumps in it. Follicular lymphoma is very common, so some of you may have this. But again, they're both enlarged. Follicular lymphoma can look like this. Also, Hodgkin's lymphoma can look like this. So there's really no way for us to look at it and say, what it's going to be, but we can say, oh, we don't see another mass, or we don't see, an infection or something like that going on. Okay, so we're still on day one, so it gets picked up by the lab. It's picked up, it may just be fresh. It may just have come out of the body and be sitting on a wet towel. And if they're suspecting lymphoma, that's often what happens. It gets picked up right away. It's still fresh. That's so that we can do some different types of studies on it if lymphoma is suspected. But if lymphoma is not suspected, and a lot of times it's a surprise, someone's getting a skin biopsy or a biopsy of their colon or their stomach or anywhere else in the body, the lung, they're not suspecting lymphoma. It will all be in fixative, which is generally formaldehyde. Okay, so we pick it up, and we have to note what's happened. And generally the surgeons and radiologists are very familiar with what needs to happen with the tissue. We have protocols, and they will, apportion it into fixative or fresh as needed. Small biopsies go entirely into an overnight processor. It's just a big machine, and it has a whole series of alcohols and of decreasing strengths, and that goes in for overnight processing. Larger biopsies, though, get divided. They get cut up into smaller pieces. Some might be kept fresh. Some might be put into fixative to go onto the processor. Some might be very slowly frozen in a very controlled way. If it's a biopsy of a bone, then that takes a little bit longer because the bone is so hard. We have to remove the calcium out of the bone so that it's soft enough to go through the rest of the processes. And that can take a long time. Sometimes when I started really taking the calcifications out of a bone took a couple of days. We then had overnight, and now there's some very rapid processes. So depending on your hospital where you're getting things done, this would delay, get a result out. The tissue is often kind of compromised after you do that, and that's just no way around it. We have to deal with bone in that way. So this is what happens. Here's that piece of tissue, and I've shown a little schematic at the top as the central section A, B, and C. And so that's what we take the first section right through the middle. We just cut through it, flay it open, look to see what it looks like. On the bottom, I have a little graph showing the specimen size, and these are all in centimeters versus what we're going to do with that. So if it's small, less than 1/2 centimeter, so that's 1/4 of an inch, we just usually do one section right through it, and it goes in one little piece. If it's a little bit bigger, then we will take a piece and do flow cytometry, as long as it's fresh tissue that has not been fixed. And I'm going to talk about flow cytometry quite a bit. And then if it's bigger, we'll take extra cuts through the middle. We'll take multiple, what we call blocks in the end. So we'll have A1, A2, A3, B1, B2. And then if it's very big, sometimes there will be excess tissue, and then we freeze that. And we freeze that in a very slow way over a couple of days. And that preserves it extremely well. And we used to do this because we really needed it for specialized molecular testing. So we do like to store that, and it can also be stored that way for, like I said, for research if the patient has consented for that. Okay, so then what happens? So it's been cut up into pieces and sent to the flow lab or the overnight fixation, or et cetera. So then now we're on to day 2. So this is the day after your surgery. You've had your surgery, your biopsy. It's actually very early in the morning, probably about midnight to 2 a.m. Okay, and we have people in the pathology lab who are coming in at 2 o'clock in the morning to get materials ready for the following day. And what they do is they get the tissue that has been fixed in formaldehyde and then alcohol. They take them out and they put them in wax. And this is what this woman is doing here. The tissue was actually in this little cassette. She's picked it up and put it in here. It's now kind of a rubbery consistency. It's a lot firmer than when it originally came out. This is a hot paraffin wax station. She's got a foot pedal. She's going to push down, and then she's going to allow the wax to just go surround the tissue and permeate the tissue. You can actually see she's got a little wax on her finger. It's an old picture. Now she would be wearing gloves. And then this creates what we call the block. And this supports the tissue and makes it able that we can now cut the tissue. Okay, so then what happens next? That block, this is now early in the morning. So the paraffin embedding starts around in the middle of the night, essentially, to very early morning. And then the cutting of the tissue begins. Those people are coming in around 3 or 4 a.m. and they try to get everything done by 8 or 9 in the morning. The following morning. So they are the true heroes that are there overnight. So these paraffin blocks, and here's what it looks like, are then cut into extremely thin, what we call the tissue sections. And we're talking microns, like 1,000th of a millimeter. Okay, so we do 3 or 4 microns thick. And this is it sitting here. This is an extremely sharp knife. And then the person goes through and they cut a little section off of it, and that goes onto a water bath, and then that gets picked up onto a glass slide. They just scoop it up onto a glass slide, and then it has to go through staining. Once it's staining, we have a final slide. And I actually have one right here next to me that I will be looking at later today. Then it's ready, it's visible to look at under a microscope. So what happens to tissue samples day 2? So this is the day after your surgery. It will go to the pathologist who's sitting there with their trusty microscope, and we're ready to look at it. And this is usually coming up. These usually get to me about the middle of the morning, sometimes earlier, sometimes depending on the volume, it might be late morning or midday. And then I get a list of your information, your history. How long has this bump been there? Do you have a fever? Do you have rheumatoid arthritis? Are you on other drugs? Do you have a history of another cancer? Usually I check the radiology. How big is it? Where exactly is this located? So then I get all that information and look at it together. The basic stain that you will see is what's called the H&E, or the hematoxylin and eosin stain. And this is what it looks like. It looks like this pink and purple swirls. And this is what pathologists do. We train for several years on how to interpret these images. And this gives a basic appearance. And I'm showing this at a very, what I call low magnification. Every tiny little dot in here is a cell, which is, from the body and from the tissue that came in. So there's thousands of little cells to look at. And they're all arranged in groups. And here I can see a group here. I can see a kind of a group here and kind of a group here. Now, to do more work on this, we could order additional stains, and we have hundreds of stains, hundreds. And they can be ordered, but we have to go back and cut that block, stain it, and then it comes out again the next day. So generally, the special stains, if I'm looking at it on day 2 and I'm ordering stains, they're going to come out on day 3. Occasionally, I need to order another set. They're going to come out on day 4. A few stains take overnight, so that takes a little longer. So generally, the stains are ready in days 3 to 4, though, and reports coming out days 2 to 7. Okay, so I've been talking about if you take the whole lymph node out. Now, you may have gone through a different type of procedure called a fine needle aspiration or a needle core biopsy, or sometimes these are done together. And I'm just showing a little diagram here of what a lymph node looks like. And there's if you just took a sampling, just instead of taking the whole thing out, a needle went through it. Okay, and you can do this, and you can just pull kind of the liquid part out of it with some cells in it and get a smear of cells. That's called a fine needle aspiration. Or you can get a needle core biopsy where they actually take a little cylinder of tissue right out of the middle. Now, this is very used very widely. It's more readily accessible because it's done in the radiology suite usually versus in a surgical suite or a surgical center. It's less expensive because of that. It's very helpful for inaccessible sites. So when somebody has a location that they want to biopsy and maybe it's very deep in the abdomen or hard to get place, you don't want to go in and do a whole surgery. Sometimes you can get in there with a needle. It's good, particularly if you're excluding metastases, such as, like I said, breast cancer coming from somewhere else or something like that. And it's also good for infection because you can get material that can go to a microbiology lab that can be tested for all kinds of bacteria, and et cetera. Also works very well for established diagnosis, like to confirm a relapse. We already kind of know what we're looking for. But when you think about it, I liken it to like if you're looking at a car. If you look at the whole car, you know exactly what you have. If you just took a core, a cylinder of the car, you might get, the side view mirror, you might get a piece of the steering wheel, the door, and then the back tire. If you're good at looking at cars, you're going to know exactly what that is, but it can sometimes be confusing because you don't really have the whole picture. This is what a needle core biopsy material would look like. And this is the schematic showing, well, down here at the bottom, actually have a patient. Here's an ultrasound guidance showing the radiologist of where to go. Here's the biopsy needle coming in, and maybe they were trying to get something right here next to a thyroid. And they can use the ultrasound. They bring the instrument up. They can put a little guide in there to say, okay, we're in the right place. They can suck up cells, or they can punch into it and get a small piece of tissue. When they come out on the cloth, this is what it looks like then. You've just got little pieces of tissue instead of that whole little lima bean that I talked about before. And on the left-hand side, you can see these floating in the specimen cup. That's what they would look like. And this might be just salt water, in which case the cells are not fixed, they're still fresh, or this could be formaldehyde. And again, every type of biopsy and location, depending on what type of things are being considered, the surgeon, the radiologist will know what to do with that. In some places, actually, pathologists will do this, not with the ultrasound, but just by hand if it's really obvious. Okay, so what does that look like? So lymph node aspirate smears would be then individual cells. You just kind of have pulled them out without taking out the whole piece. You don't have it all arranged. So that's why I say there's no tissue architecture. And here's what it looks like at the bottom, just individual little lymphocytes, and the background is just sort of water and fluid. There's a few different types of cells in here, a little bigger, a little smaller, and there is a whole specialty called cytopathology that those pathologists just specialize in reading out these types of smears for us, and they're very good at it. A needle core biopsy then looks like, exactly like I said, a cylinder of tissue. And this is a case that we had earlier this year. Here is that long cylinder of tissue. They actually did it twice, so they had 2 pieces. This first piece, the tissue was all dead. So the cells it actually turned out to be a tumor, and they had grown, but then the cells had died, lack of blood supply or whatever. They had died. And then then we have some other tissue, again, some multiple dead areas, but some areas that look like they have cells. And here is a higher power on the right-hand side. And each little dot here is one of the cells. This ended up being a diffuse large B-cell lymphoma. Some of the area was a little bit crushed, or et cetera. So we were able to find some interpretable areas. So you can get, like I said, in this case, we had some liver, some dead tissue, but some alive tumor that once we fixed it, we could interpret. Sometimes, as you can imagine, though, it doesn't capture the needed key tissue, and they have to go back. But usually when they're doing a core, if possible, they'll get multiple cores, and the more tissue, obviously, the better. I'll just share with you a paper that came out from in last July. This is from France, and in France they have a single medical network for the whole country. So they have what they call the lymphopath network, which means that every single person in France who has a diagnosis of lymphoma, their biopsies are sent to a central location where pathologists who only specialize in lymphoma reread all those biopsies to confirm or et cetera. So this is a study of 32,000 cases. They did cord needle biopsy, and they had 92% of them got to a complete diagnosis. So really pretty good. If you actually take out the whole lymph node with a surgical incision, they got about 98%. So of course it increases the amount that get to a complete diagnosis. A couple interesting things, though, that when they compare the referring pathologist to the expert, the discordance rate or the disagreement was higher for the needle biopsy. So if you have the needle biopsy, the local pathologist will look at it. You give it to an expert, there's going to be a slightly different opinion more often than if you have a whole piece of tissue. It makes sense. It's just harder to look at. They also had more frequently what we call unclassified on the needle core biopsy. We just say it looks like lymphoma, or maybe we look like B-cell lymphoma, can't say too much more than that. And then the diagnostic concordance for reactive lesions that are not lymphoma, the agreement was higher, again, with an excision. So if you have all the tissue, you're more confident to say no lymphoma there. Then if it's part of the tissue, you can say looks pretty good, can't be sure what about it. So that's a little bit higher. So those are just the pluses and minuses of the different types of procedures. Now, a lot of people with lymphoma also get a bone marrow biopsy, and this is for staging of the lymphoma to see if it has spread to the bone marrow. It's also a convenient place sometimes to get diagnostic tissue. So, for example, this week we had a patient who they tried twice to get into a location really deep in the retroperitoneal, I call the deep abdomen, couldn't really get tissue. But a lot of lymphomas do spread to the bone marrow. And getting a bone marrow biopsy could be done by a hematologist, medical oncologist, or even a well-trained nurse will do that as well. So it's sometimes a place that we can get tissue and we can actually make a diagnosis of lymphoma. So there's two parts to the bone marrow procedure. The first one is the liquid bone marrow, and the second one is taking the biopsy. So this is just showing a schematic of the bone. There's a little bit of fat, and then this liquid bone marrow on the bottom. So inside of the bone, and that is where the cells are that make your white blood cells, make your platelets, and make your red blood cells. On the right hand side, I'm just showing a picture. This, don't worry, it's not that big. This is actually someone who is doing a bone marrow harvest, and they are donating their bone marrow to another person who's having a bone marrow transplant. But I just wanted you to see the patient may be laying down, and they go into this part of the hip bone. This is what the bone marrow aspirate will look like. We have on the left-hand side a normal bone marrow aspirate with all different types of cells. This big cell here is called the megakaryocyte. It makes the platelets, the little clotting factors. We also have a lot of cells like this and this and this and some of these other ones. These are making your usual white blood cells that fight off infection. And then we have these little round ones in here. These are actually all going to be red blood cells when they grow up. Now, usually in the bone marrow, there's not that many lymphocytes. There's a few, and I'll just point out because this is actually a lymphocyte here, for example. But if we have a lymphoma, obviously, there's going to be a lot more lymphocytes. So on the right-hand side here, I have a chronic lymphocytic leukemia, or small lymphocytic lymphoma, we call it. And you can see we're missing all the different types. We just have tons and tons of these lymphocytes all over the place, and then a few little of red blood cells in the background, maybe one white blood cell. So we can tell right away this doesn't have the mixture of cell types. This is probably this is going to be a lymphoma. Then the second part of the bone marrow procedure is the biopsy. So after they take the liquid out, then they go in with the little core and they get the little cylinder of tissue. It's a little tough because there's bone, so it's a little hard to get in there. On the left-hand side is the normal, and this big finger here and this and this. This is actually little pieces of bone. And then in between are all those cells that I just showed you. You can see those big cells. Actually, this is a lower magnification, but I can see different types of cells in here. I can see erythroid cells and etc. On the right-hand side is a bone marrow core biopsy that has a tumor in it. And you can see the bone, and then the whole thing is completely altered. I forgot to mention this white part over here. This is fat that's in there. So the bone marrow is a mixture of fat and cells. Over here, the fat's been all crowded out. It's just all filled up with cells. Now, we don't always get this where it's all one or the other. In fact, the bone marrow often can have a very small, little subtle infiltrate. Sometimes we'll just have a little spot, this big maybe with 20 or 30 cells that are abnormal. But we have very sensitive techniques, and we're good at looking at these, and we can figure that out. So talking about the liquid bone marrow is my introduction to talk to you about flow cytometry, because you may have heard your doctor, or you may see it on your pathology reports, something about flow cytometry was performed. So they take those liquid cells and they're in a suspension. So think about them floating in some fluid. And so, it's very helpful on blood or the liquid part of the bone marrow, but we can also take a piece of tissue, a piece of lymph node or skin or whatever, and we can mince it up very fine, push it through a little mesh, and we can get the cells kind of floating in some salt water, and then we can use that for flow cytometry. And this is just a picture of some cells that are in a suspension. So why is flow cytometry important? Well, it's often the fastest done. It's actually often done day one. So if you had surgery in the morning or biopsy in the morning, it would get picked up right away. If it's fresh, the decision to go to flow cytometry or not will be made within, probably by the time you get home, someone's already decided whether it's going to go for flow cytometry or not. And so we get that information out, and we get a lot of information about the proteins that are on that piece of tissue. So here I'm going to walk you through what happens with flow cytometry. So we have these cells over here, and they're in a suspension, and we stain them with little fluorescent molecules to red and yellow and green. We also use purple. We have kind of an orange, and etc. So the cells are stained, and they pick up different types of proteins, and then they're kind of tagged with different colors. The next thing that happens is that the cells go through the flow cytometer. They one at a time, so they just get sucked up and they go through the flow cytometer. And then we have a laser that hits them. Actually, we have multiple lasers of different wavelengths, but we have a laser that hits them. And then the next thing that happens is that laser scatters all the light. So the purple, the red, the green, and actually the regular light all get scattered, and that gets picked up by a whole series of detectors. And then the next thing that happens is that data all goes to a computer, and we can analyze it. And we can do a lot of things with that data. Now, this is a picture of what flow cytometry data might look like. This is what a lot of us hematopathologists do. I have a flow cytometry study right here I'll be looking at later. So on the left-hand side is pictures of different types of cells. And these are just drawings, but because of our experience, we know exactly what type of cell will have what type of characteristics. This is actually, every little dot on here represents a different cell. Generally, we will look at like 30 to 50,000 cells. In some cases, we'll look at 100,000 cells. So really looking at a lot of material. And this is a lymphocyte here. And we know, for example, that using a combination of an antibody called CD45 and a certain type of light scattering. We know that the lymphocytes will fall in the bottom right corner. That's just where they fall. We know that regular white blood cells will come up here and kind of be in the middle or the top. We know that plasma cells will fall over here. We know that blasts might fall here. Okay, so we have a pretty good idea from experience where everything is going to fall. And then the real strength in flow cytometry comes with the electronics, the this computer software that we can use. We can say, okay, we're looking for leukemia. We're concerned about this group of dots that are all right here. So we can tell it, okay, just focus, just show me information on that group. And I'm showing you here as we, the computer will just start grabbing that information. And we call this gating. And this is how we can hone down on small populations. We can then tell the computer, okay, of this group here, just look at these. What about some other proteins? In this case, I have CD34 and CD33. This is for an acute myeloid leukemia. And these cells are positive for both of them. So it's a lot of information. Then we can go and say, what about these cells? What about these cells? What about some other combinations? We get like a 20 or 30 page printout with all of the patterns. And this is how we can pick up very, very small little groups of abnormal cells and look at multiple features. The other way to get at all the proteins on the cell are to do special stains that I mentioned before. So this is called immunohistochemistry, and they come out one at a time. It's a little bit harder because each one, this is a series of 4 different stains, actually 12 different stains altogether. And we have to look at each one and judge it. And in this case, brown means positive and blue means negative. So this is a mediastinal large B-cell lymphoma. I don't know if I can move that. Yes, I can move that. Great. A mediastinal large B-cell lymphoma. And I can say, okay, it has this protein called CD20 on it. It has BCL6. It has a little bit of this MAL. It has BCL2, some of MUM1, and this is a proliferation marker. Ki67 tells you how rapidly this particular tumor is going to divide and proliferate and et cetera, which is pretty high. And then it's negative for these other things. So we can look at these. It's a little more tedious. It's one slide at a time and trying to judge the intensity of the color and the percentage of cells that are positive. Okay, so if we, let's see, where do we go? Okay, so techniques for diagnosis then. Basic, all lymphomas will get the basic appearance on the H&E stain slide. And then we want to look at the proteins expressed, and that's 2 techniques, the immunohistochemistry and then the flow cytometry. Okay, now there are a whole slew of advanced techniques, and it depends on the type of tumor that's being suspected. So you may have heard of cytogenetics or karyotyping. That's looking at the chromosomes in the cell. That needs living cells. We have to have fresh tissue. Generally, this is done in bone marrow. We also have FISH, or fluorescence in situ hybridization. These have little probes that look at particular regions of chromosomes, and that's important for certain types of lymphoma. We have what's called PCR, which will look for small little rearrangements of chromosomes or particular mutations. We can sequence it looking at all of the little base pairs of the DNA, and we can do large panels. We can even do all genes, whole exome sequencing or whole genome sequencing. And then there's gene expression profiling that looks at the pattern of gene activity. So, and all of these can be applied, and they are applied in different situations. And finally, we get to the pathology report, and more people are viewing and seeing their pathology reports in their medical portal. It used to be, it was pretty rare for a patient to look at their pathology report. Now I think people are looking at them. And so here's just a patient example. You're going to have a medical record number, date of birth, gender, and then who's the doctor that ordered the biopsy, wants the interpretation, and then who else is getting a copy of this. Down here is generally a list of all the tissues that were taken out. This person had 7 different biopsies going on in that day. And then the diagnostic report. So we have an interpretation, sometimes it says final diagnosis, and this is where your pathologist here, it says LungPath MD, has said, okay, this is what we have, a moderately differentiated adenocarcinoma. It's what stage it is, positive in this case for what's called EGFR, an important protein for which there's a particular treatment. So it's important to look for that. Negative for this other protein, which also has a treatment. And then at the bottom is usually some more description of the different types of samples that were taken. Sometimes there'll be a description. It was, so big and it looked like this, and this is what we did to it. And then sometimes the pathologist will also have some comments about what it looked like, why I ordered these stains, and a whole description. So that's what it'll look like. Now, occasionally we'll put something out quickly because we know you're waiting, we know your doctor's waiting. We'll say, looks like lymphoma, looks like a high-grade lymphoma. We think it's a B-cell lymphoma, but we're going to have to do more of the advanced studies. But we'll get this out now, and then we'll add more information. So then an addendum might come out, that's adding information, or sometimes it will get an amendment, meaning we got more information and it actually changed what we initially thought. So those may follow. But usually when we're doing a preliminary, we say this is a preliminary report, but we want you to have something so you can get started with other studies or et cetera. So that's what happens with your biopsy, which was the bulk of what I wanted to talk about today. So now I'm going to talk a little bit just about what is lymphoma. And I think most of you know it's a cancer of the lymphatic system, and the lymphatic system really takes, drains the fluid coming out of the body, and it kind of parallels the blood system, right? And it picks up debris and bacteria and et cetera. When we talk about big lymph nodes, we use the term lymphadenopathy, just means big lymph nodes. And in this case, we have 4 people that have big lymph nodes. Now, 2 of these are benign, and it's this one. This is somebody with infectious mononucleosis. It's big. It probably was sore. They probably have a fever or sore throat to go along with it. This person actually has a skin infection, and the lymph nodes down here are involved. This is a small little lymph node here, which is very hard and firm. This actually is a lymphoma, okay, at the patient of HIV. And this is obviously a lymphoma. It's just way too big almost to be anything else. Okay, so we talk about big lymph nodes, though, most commonly they're benign. I mean, lymph nodes are there to react to any kind of tissue, any kind of infection, or et cetera. So especially in the neck, most lymph nodes will be benign. But if they persist, they should obviously be evaluated. Secondly, if a lymph node's enlarged, it's usually most often a metastasis coming from another tumor if it's not benign, and it's spreading to that lymph node. And then a primary lymphoma is actually kind of the third down the line of things. But when radiology looks at it, they usually will tell us this looks like a benign lymph node, or this could be a met. They'll usually have some impression. The basic divisions of lymphoid cancers then are non-Hodgkin's and Hodgkin's lymphoma. Non-Hodgkin's lymphoma can be divided into immature cells, which are really the acute leukemias, or mature cells, which are the lymphomas. And then we divide them into B or T cells, which are the 2 main types of lymphocytes. B cells make antibodies, T cells kill other invading organisms directly. And there's like 80 subtypes of these. And so there's a lot of different types of lymphoma. Hodgkin's lymphoma is separate, and I'll explain why. There's several subtypes there. The most common type of lymphoma is a mature B-cell lymphoma. It accounts for like 3/4 of all lymphomas, and the rest of them are behind that. Okay. So classification, how do we do it? How do we come up with these names for these different types of lymphomas? Well, it's really based on the type of lymphocyte, and we base it on lymphocytes start in the bone marrow, and then they go to a lymph node. They may be exposed to an antigen, make antibody. They might become a memory cell. This is all kinds of immunology that is known. And then we classify lymphomas based to the type of normal cell they correspond to. So we can really do this based on the appearance under the H&E, and also looking at the type of cell with the flow cytometry and the special stains. And so it's really available anywhere in the world, and it works very well. Some of the weaknesses might be an oversimplification, even though I just said there's 100 types, there's probably more types than that because there's so many different stages of lymphocyte development. And it may not really guide treatment choice. Doing it this way doesn't tell us there's a particular mutation or et cetera. I mean, sometimes it runs with the diagnosis, but sometimes there's something more that we could learn. So we're trying to go now into a kind of a more nuanced, more information per each case. This is the book that we use. It's the WHO classification of tumors of the hematopoietic system. I keep it next to me. Here it is. It has all the information on all the types of lymphoid and also leukemias and myeloid disorders. Okay, so general features, as I've said, you've got to do a biopsy and a microscopic examination. Radiology or looking at your blood levels or whatever only gets you so far. You really can't make a diagnosis without looking at the tissue. We have a very wide range of behavior from very, very slow growing things to things that grow very fast and might be aggressive and et cetera. So when someone says they have lymphoma, it could be, well, you're going to have that for 20 years. It might not affect your lifespan to you're probably going to be in the hospital the next week getting treated. Lymphoma cells, those circulate through the blood and the lymphatic channels, which is what they're supposed to do. That's what normal lymphocytes do. They're traveling all over your body, checking for infection. So lymphoma occurs anywhere in the body. It's not, and this is hard for people to realize. It's not like breast cancer occurs in the breast and lung cancer occurs in the lung and kidney cancer occurs in the kidney. No, lymphoma can be anywhere. So sometimes it is a surprise. And about 30 or 40% of the time, it's not in a lymph node. So it can occur anywhere. So now I'm going to show you a series of pictures. And I hope that that they are of interest of different types of lymphomas. So this is a lymphoma. This is what's called a malt lymphoma occurring in the eye. And you can see someone's eye here, and you can see all this red tissue. This is all lymphoma. Sorry, these are a little more pixelated than they look like on my screen, so they're not that clear. But this is an endoscopy picture of a stomach, and this person has ulcers, and then there's heaped up tissue around there, and there's actually lymphoma there. Here's some skin lymphomas. This one's very flat and kind of red looking, as you can see. This one is actually a single big lump. This is another one that looks like little pimples that kind of come and go, and they get necrotic and they crust over. They can cause scars, and they eventually get worse. So all types of appearances. These are lymphomas involving deep layers of skin and fat. This is a rare type of lymphoma that likes to occur on the lower leg. We don't know why, maybe slightly cooler temperatures down there, but it involves the skin, but also deep tissue. And then this one here is actually not involving the skin so much. This is actually involving the fat under the skin. So the skin looks like it's been depressed in, right? And this is a paniculitic lymphoma. So different types of appearances even in the skin. This is a lymphoma occurring in the jawbone of a young man. This is a Burkitt lymphoma, and it looks really terrible, but actually it's so quickly growing that it's very sensitive to chemotherapy and likely has a very good outcome. You can also have lymphoma in deep tissues. This is a spleen, and it's been cut. So you can see what we call that cut surface or that section. And the dark red is the spleen, but these little white bumps in here, these are all little colonies of lymphoma. Over here is a bunch of big lymph nodes came out of the abdomen for the belly, and that's actually diffuse large B-cell lymphoma. A few more pictures. These are cases I photographed myself. These are on the top here is T-cell lymphoma. This is the skin, some tissue underneath. The dark red is the muscle with a lymphoma in the middle. This is actually a thyroid gland. You can see the person examining it, went through and sliced it every half an inch or so, examining it, looking for any irregularities, special areas that might be sure to be sampled. And then this is a brain lymphoma. This was from an autopsy. The white matter of the brain, the gray matter, and then, gray matter and white matter. And then you can see this soft area that kind of looks gelatinous, like it's falling apart. This area had the lymphoma in it. So we can't go into the 180 different types of lymphomas. So I'll just mention there's 4 common types of lymphoid tumors in adults, mature B-cell lymphoma being the most common, follicular lymphoma, and diffuse large B-cell lymphoma. I'll show those in a minute. chronic lymphocytic leukemia, which is also called small lymphocytic lymphoma. I showed that in the bone marrow earlier, and multiple myeloma, which is really kind of its own area of diseases. And then the two most common in children are lymphoblastic leukemia lymphoma, which is really the kind of more on the leukemia end of things, and that Burkitt's lymphoma, which I just showed you in the jaw tumor. So this is follicular lymphoma. It's called that because lymph nodes show these distinct, what we call follicles, which are really these nodules. I can see one there, I can see one there, I can see one there, I can see one there. And when we look at it, it's super high. This is 400 times magnification. We find these little small cells in here that are all kind of twisted and irregular, and it's kind of a slow growing lymphoma. Diffuse large B-cell lymphoma, equally very common. These two together make up, the bulk of lymphoma. And in this case, we don't see those nodules. When we look at it very closely, we see these kind of larger cells here. Here's one here, here's one here, here, and here. So they're large cells. That's why it's called diffuse large B-cell lymphomas. And this one's pretty fast growing. Now, Hodgkin's lymphoma has a very unusual look to it and also pattern of behavior. So it has this large cell that we call the Reed-Sternberg cell, named after two pathologists, and it's very distinctive. But also what's distinctive about it is the pattern of spread is very predictable. It starts in the lymph node, and then it goes to another lymph node up the chain, and then to the spleen, and then to the liver, then finally to bone marrow, other places. So that's different than non-Hodgkin's lymphoma. It can start anywhere, and I told you 30 or 40% of the time it's not even in a lymph node. But then when non-Hodgkin's lymphomas spread, they can spread kind of randomly because they can go through the bloodstream. So you might have it starting under the armpit in the lymph nodes there, and then next showing up in the liver, and then showing up in the skin, and so it can kind of be random. But Hodgkin's doesn't do that. So this is what the cell looks like in Hodgkin's lymphoma. It's a two-part nucleus. We have two parts to that and two big, what we call nucleoli in the middle. We always say this looks like an owl's eye. And so I always tell the medical students, remember that. And the interesting thing is that these cells will be very rare in the tumor. In fact, the bulk of the tumor is not even the actual tumor cells. So if you have a big piece of tissue, you may have these cells, and we search around looking for them. There's an abnormal. This one's going to probably become abnormal, but then there's hundreds of other little cells in the background that are benign. And sometimes the malignant cell is only one every 500 or 1,000th cell. So, but they recruit other cells to come in, and it makes a tumor. And then this is the nodular sclerosis subtype, which is the most common. So my last point I want to make is just how we do this diagnostic process. And it starts on the bottom with the clinical variables. So that's you. How old are you? Where is this thing located? How long has it been there? What other diseases do you have? What other medications are you on? That kind of thing. And then it goes to the morphology. What does it look like? And then the lineage. Is it B or T? The stage of differentiation. Is it advanced cell or is it an early cell? Phenotypic aberrations, these are just weird proteins. We look at the clonality. Are they all related to each other, or are they not related to each other? And then the special things, the cytogenetics, the FISH, molecular profiling, and targets of therapy. So we want to see, are there special things that we know we have drugs to that we can use for this disease? So basic diagnosis, I'd say, is available anywhere. That's the clinical information, obviously, the morphology, and some of the special stains. If not flow cytometry, then at least special stains. More specific diagnoses would be available at most major centers. So that's where we look at more at the clonality, cytogenetics, and FISH. And of course, small hospitals can mail their things to reference laboratories, and that's generally what happens in the country. Smaller hospitals or locations will send it to a reference center. And then a molecular profile might be done, which gets at a very refined diagnosis and some biomarkers. And then targets is, are we looking for particular things that we can target with treatment? Want to mention the two types of biomarkers. We have prognostic markers, which just say how aggressive is a disease. Is it going to be one that's going to behave very badly, or is it going to be one that's going to be what we call more indolent? And then we also have predictive markers, which predict response to therapy. And generally, it's tied to a specific protein or specific genetic abnormality. Just 2 slides left. So this is the kind of thing we're looking at in the future. This is a picture of all kinds of information profiling tumors from 100 different patients. It starts at the bottom with what clinical information. This is mantle cell lymphoma. We have something called the MIPI score. Again, your age, the stage, some things about the blood work, and et cetera. But clinically, they can look and say likely to be aggressive or not. Ki-67 measurement of the proliferation of the tumor. TP53, this is a gene when it's mutated. We can also look at it with immunohistochemistry. If that's there, that's generally means something worse coming out. Morphology, we can look at little details. And this is what I call the Christmas tree plot. It's all red and green. And this is a pattern. This is a whole bunch of genes. And red means overexpressed, green means underexpressed. So you can say, okay, these are the really high risk people. Overexpressing these genes, having certain morphologic features, having P53, having Ki-67 certain level, and having certain clinical features. So this is what your medical oncologist does. They take all this information and then they'll put that together. So the glimpse of the future, this is where classification is going to go. We're still going to always have the basics, and maybe we can get you into diffuse large B-cell lymphoma, but in the future, we'll be looking at things like chromosome changes, translocations, gene copy numbers, mutation patterns, how the DNA is packaged, how the RNA is functioning, a lot of other things, to go from 3 or 4 basic groups to maybe multiple groups. And right now we have 7 additional groups. This is research only, but we're predicting that knowing a subtype will then predict particular types of therapy that patients can get. So this is what we call predictive biomarkers. I'll just mention our research program starts with the tissue in the lymphoma spore. I also work with the AIDS group and the Southwest Oncology group that does clinical trials. I do a lot with different techniques and collaborations with different companies actually employing new techniques. And the goals are more accurate diagnosis, assay development, prognostic markers, predictive markers, and then supporting these clinical trials as they test new therapies. So that's the bench to bedside approach, and I'll thank you and stop there.